So, the topic is types of study, cross-section and case control. Now, what questions can you expect from this? What questions can you expect from this? If you know the question and how to write the answer, you'll pass. But if you don't know it, you'll suddenly leave that question. It's usually the first question in a question paper, and 20 marks, 15 marks, whatever it is, goes down. So, let us look at the questions. The questions, university exam questions. Okay, these are the university exam questions. What are the indications of a cohort study? Mention the advantage of a cohort study. State the steps of case control study. All in the same question. Okay. So they have taken cohort and case control in the same study. This is a question which appeared in the university exam. So this is usually the first question in your exam in your theory paper. So if you can't answer it or you cannot understand it, it upsets you. So your remaining questions will also get affected. Next question, again, what are the indications of a cohort study? Mention the advantages, state the steps of case control study. Again, that question has been repeated. Define epidemiology. How do you estimate the disease risk? What are the biases in case control study, including the process of elimination as applicable? 60, that has so many marks, 12 marks. Enlist the type of epidemiological studies. Discuss the importance of incubation period in epidemiological studies. Describe different time trends in disease occurrence. Okay. So this is basically to do with epidemiology more than case control and cohort, but I just thought I'll put it in. Then, what is epidemiology? What study will you do to study the association between lung cancer and cigarette smoking when the sample size is 250? Okay. This is a question which is asked in the university not once, twice. And this one is slightly different. On your rounds, your senior doctor says that prevalence of stomach cancer is increased. And the recent cross-sectional study is the main risk is smoking. How do you go about proving the hypothesis? Means, how do you say that smoking is actually causing an increase in cancer? It's not a straightforward question. It's crooked. It's a googly. Then, what research study will you do to confirm the diagnosis? Steps to conduct the research design. How to analyze the research. This is not from Calcutta University, from West Bengal University, some another university, but the question is relevant. Okay. Another one, a professor in surgery is saying that he was explaining to students that cervical cancer is replaced by breast cancer these days. He said to check all the records and see what caused it and how long they lived. What are studies, designs you wish to imply and why? Okay. So, with this background of questions, let me move on a bit. Okay. So, as you can see, these questions are very straightforward but also tricky. So, unless you get a concept is clear, you will not be able to get it. So, as I told you, epidemiological studies, you have experimental and observational. Among the observational, you have analytical, which is case control and cohort, and it's also called cross-sectional, and descriptive, you have longitudinal and cross-sectional, and again descriptive, you have ecological. Okay. Among the experimental studies, you have a clinical trial and a field trial and community intervention trial. So clinical experimental epidemiology means you're doing some procedure. Say for example, robotic surgery. Is robotic surgery better than conventional surgery? Okay, so that you need to do a clinical trial. You need volunteers to do it, etc., etc. Or some new medicine for cancer or some other thing. Is it good? Some new medicine has come for pancreatic cancer, for example. So for that again you do a clinical trial or a field trial, and you can also have a community intervention trial. So getting back to the previous one, cross-sectional study entails collection of data. A cross-section of the population comprises the whole population or sample of the whole population. Okay. We talked about it in this last class. We don't need to go any further in that. Also called prevalence study, number of prevailing cases divided by estimated population into 1,000. So here observational study, single examination of population 1 point, individual based measures exposure and effect. Exposure precedes or follows the effect. It can be before or after. That is observational study. Okay, just you're observing it at this point of time. At this point of time, you're just observing the persons. I'm observing all of you right now. But I'm not doing anything further. Some of you are writing, some of you are looking at your mobile phones, some of you are looking at your tabs, some of you are following the class. Now you have descriptive cross-sectional study, you are seeking information about single or multiple variables. You're not just the cross-section, you're looking at various factors. These are called variables. And you're estimating the problem. What is the problem? Say for example in the field area where you went, Muluk or Nanur, say you have a number of cases of anemia. What is the reason for anemia? Or number of cases of jaundice. What are the reasons for jaundice? Okay, so estimate the problem and the prevalence. So descriptive cross-sectional study, presence of disease, disability, symptoms of ill health, dimensions of positive health such as fitness, attributes related to health like body measurements, blood pressure, etc. Okay, now this is the basic thing of a cross-sectional study. Exposure, effect, disease among those exposed, disease among those who are not exposed. 4 categories basically. Characteristic and disease outcome, characteristic and no disease, no characteristic but yet the disease, no characteristic and no disease. So, the steps in conducting the cross-sectional study. State the criteria for the disease clearly. For example, if you are saying that the criteria for anemia is so much, you are saying anemia cases. You are looking at study of anemia cases. So, what is your definition of anemia? What is the definition of anemia? What is the definition of anemia? Reduction of blood. No, reduction of blood what? Huh? Okay, hemoglobin count. Below what? So below what? That is the question. So he said reduction of hemoglobin count or RBC. I'm saying RBC. But below which? Below what? What is the cutoff mark? So for men it is so much, for women it is now so much. So what is your definition of anemia? So the criteria for the disease condition should be clearly mentioned. Define covariables to be measured. Say for example the anemia case I'm talking about. You are looking at the height and weight also. You are looking at the BMI also. You are looking at gastrointestinal symptoms also. So all these are the covariables. Examine the ethical issues. If are there any ethical issues involved in the study? By ethical issues we mean normally, usually for cohort studies. What is cohort study? We'll come to it shortly. Ethical issue means you're doing a study. For your study you're doing it, but you're not doing the right thing. Okay. You want to say, for example, you want to find out how many times this guy has alcohol, but you're not telling him to stop the alcohol. That is all the ethical issue. Then identify the reference population, inclusion and exclusion criteria. Who is to include in the study? Who is to be excluded in the study? Determine minimum number of samples required. Now, this is important. You cannot do everything. Say, for example, you're doing a study on school children. Okay. So how will you do a study on school children? If you're doing a study on health problems among school children, how will you do a study? Health problems among school children. How will you do a study? You want to do, okay, I'm giving a specific, anemia among school children, how will you do it?
Cohort study of the diseases they face in 5 years.
No. Cohort study, then forget about cohort study. How will you do the study? Specifically, you're doing it in schools, how will you do it? I'm doing a study on anemia among school students.
So I will give them a questionnaire which they have to fill by their parents.
Okay, filled by their parents. Okay, fine. He's come partly correct, filled by their parents. Now the question is, I said school children. So I have to specify what school children. School children can be from KG to class 5, 5 to 10, 11, 12 is also thing. Number one. Number two is, How many schools will I take for it? How many schools should I take?
So,
How many schools should I take?
at a PhD level, all the schools at a PhD
All
level.
the schools at the PhD level. How many schools are there at the PhD level, roughly? Government and private, how many schools are there? Just make an assumption.
So 5 to 10, sir.
5 to 10. So you're taking all school children of 5 to 10 schools. That means there are 5,000 students. Away? Away? 5,000? No. It's not possible. So we cannot get all the students. So we have to take a sample. So there is a certain formula for taking sample. At the same time, that should be representative. Representative means you're doing taking anemia, studying anemia pregnancy among students of, say, Kendriya Vidyalaya, and you're comparing it with the government school. They may be different, or some private government school with a government school. So they may be different. So you have to take a suitable sample. Okay. So first the sample size and the sample quality also. Okay. Select study subjects to appropriate sampling procedure. Define measurement procedures. Carry out data collection and clinical examination where necessary. Now again, back to the same thing. Disease, risk factor, exposed, not exposed. What are the total number of cases in this population? What are the total number of cases in the population? What is the total population? What is the total population?
A plus B plus C plus D.
A plus B plus C plus D. Okay, fine. Now, how many people are exposed? How many people are exposed to the risk factor? How many people are exposed to the risk factor? Don't look at your friend, look at the board. How many people are exposed to the risk factor? How many people are exposed to the risk factor?
Total A plus B.
Yeah, A plus B is exposed to risk factor. How many are not exposed to risk factor?
C plus D.
C plus D, okay, fine. How many have the disease? How many have the disease?
A plus C.
How many don't have the disease?
B plus D.
No, okay.
So B plus D.
Huh?
B plus D.
B plus D, okay. So A plus C has a disease, B plus D don't have the disease, okay. Now, so once you get this in your head, the remaining things become okay, right? So disease is present in A plus C, disease is absent in B plus D. So here again, the same old problem, 1,000 people, about 30 years examined. We are looking at the blood pressure, and this is a fact, this is the thing. Now, what is the total number of people in this sample? Total number of people in the sample, how much? How many are there? Total 1,000, okay. So how many are exposed? How many are exposed? 400. How do you say 120?
Okay,
Dekh
I just read.
You just read what? See that whole line. Okay. 120 plus how much? 120 plus
280.
280. That is okay. And how many are not exposed?
600.
Not exposed to 600. Out of which, how many of them they developed have hypertension? Out of 600, how many have hypertension?
1,000, sir.
Huh?
1,000.
How many have hypertension among the 600? Huh?
570.
570.
No.
570. How many are, okay, let's put it this way. I am also not saying from this, I have also got eye problem. How many people have disease? How many have hypertension? How many have hypertension total?
So 150.
150. How many are smokers among the 150?
Smokers.
How many are smokers among the 150?
120.
How many are non-smokers among the 150?
30.
30. Okay, very good. And how many are not exposed at all to? Not exposed to the thing. Huh? देखते बच्चा ना ना वो बोल ना okay you cannot see that सामने show come in front if you cannot see because if you can't see this you will miss the thing. Okay, that's why at least for some time you come in front, last bench. जरा देखते बच्चे ना please come in front. Without that it's not possible. You can't see, you cannot make a guesswork. Those who can see, they are able to understand. Okay. So if you can't come, there is the AC there, you can come here. Okay. Now, so total people who are having the hypertension is 150. 850 do not have hypertension. Total 1000 population. Okay. Now, risk factor smoking. You have 120 plus 280, 400 smokers, right? 400 smokers, non-smokers you have 600. You have 150 people who have hypertension. So how many percentage of hypertension among smokers? A by A plus B. 120 divided by 150. Is it clear? Is this clear? This part clear? Percentage of people with hypertension among smokers. How many have hypertension? How many have hypertension? In this figure, how many have hypertension? How many have hypertension? How many have hypertension? How many have hypertension? You are making this side, you are not able to see. Okay, I'm just pointing. Unless you come in front, you can't see it. And here there's no AC, of course. So, just for your help, for those who can't see, 150 who have hypertension, out of which 120 are smokers. So, prevalence of hypertension among smokers is 120 divided by 400. I mean, sorry, 120. Oh, sorry, this is prevalence of hypertension among smokers. Total smokers is 400, 120 plus 280, out of which 120 have hypertension. So, A by A plus B, 120 by 400, which is 0.3. Can last bench, can you see this part? Huh? Likhte bachcho? I am just repeating the figures. Maybe you can write it down on a small paper. Total people who are exposed, total number of smokers are 400, out of which 120 have hypertension. So among the smokers, how many have hypertension? 120 by 400, roughly 0.3. So prevalence of hypertension among smokers is 120 by 400, 0.3. Similarly, hypertension among non-smokers is C, but still he's got hypertension, 30 divided by 600. 30 divided by 600, which is 0.05. Okay. Is this part clear? So if you look at the, next is the odds ratio. Prevalence among exposed by prevalence among unexposed is 0.3 by 0.05, which is 6. But more important than that is the odds ratio. For the sake of your examination, odds ratio is AD by BC. 120 into 570 divided by 280 into 30, it comes to 8.14. So what does 8.14 mean? You have an odds ratio of 8.14. What does it mean actually? What does it imply? It implies something, we'll come to that a little later. Before that, let's go to the case control study. So here is a study that compares patients which have a disease with patients who do not have the disease. And it looks back retrospectively. Retrospectively means the event has occurred. Somebody's got cancer, he's already got cancer. So the event has occurred. Somebody's got some other disease, diabetes, the disease occurred. Somebody's got some other disease, disease occurred. So the disease has already occurred. Okay. So you're comparing it with controls. It looks back retrospectively. This is also called retrospective study or a case reference study. These studies are designed to estimate odds. The odds of an event represent the ratio of the probability that the event will occur divided by the probability that the event will not occur. Okay. Now, it's like saying who's going to win, Argentina or Brazil. What is the probability that Argentina is going to win? What is the probability that Brazil is going to win the World Cup? So a lot of factors, something like that. So here is a very important thing. Case. Case is a patient, is a person in the population who is suffering from a disease, who has already been diagnosed and conditions under investigation. Control is a person or persons in a comparison group which does not have the disease, but other ways it is comparable. Say for example, patients coming to a hospital with cancer. There are other patients who also have come to the patients, but they don't have cancer. That is a control group. Patients with cancer, patients without cancer. Both come into the hospital. Okay. But not having the outcome being studied. So here, both incidence and exposure have occurred. Like, coming to the cancer scenario which I talked about, you're studying, say, the effect of some pollution, radiation which caused cancer, or pollution which caused cancer. Both incidence and outcome have occurred. The study proceeds from from effect to cause. Now, suppose, for example, there's some industry or something, and from there some people have got cancer. There are other people also who have not got cancer. So we are using a comparison group to support or refute an inference. So it moves from effect to cause, moves backwards, and it uses a comparison group to support or refute an inference. So, design of a case control, cases have the disease, were exposed or were not exposed. Controls do not have the disease, were they exposed, not exposed. Okay. So coming to the example of cancer patients, look into the histories. In control group also look into the histories. So this is, you have some people who have got cancer have got exposure, some who have got cancer have got no exposure. And in control group, some people may have not been exposed to risk factor, but they also have cancer. So this is the basic thing, identify the risk factors. Selection of cases and control. Second one is matching. Now matching means, what is matching? Matching basically means you are trying to bring the case and control as close as possible. What do you mean by as close as possible? A 25-year-old, you're taking a person from the same village, 75-year-old man with cancer. And the control you're taking, a 25-year-old man with a 25-year-old college student. Is it correct? Why not correct? 75-year-old man with cancer and a 25-year-old student who does not have cancer. Is it correct? You said no.
It's not.
Why not?
They are grossly different from each other.
Oh, what is the grossly different from each other?
The age difference is.
Age difference, exactly. So you have to match as far as possible with age, as far as possible with sex, and whatever else. Okay. So again, matching somebody who comes to say Calcutta Medical College, he's got cancer, he comes from say Midnapur. Another person who doesn't have cancer, he's from Calcutta, proper Kolkata. So again, matching is a problem. Socioeconomic status may vary and other things. So you have to match it as much as possible, both the control group and the case. Case we cannot match, but the control should be matched as closely as possible. Measurement of exposure, analysis and interpretation. So, definition of case, diagnostic criteria, then what is the eligibility criteria? Say for example, we are looking at dengue cases. Okay. Clinically, dengue is a laboratory diagnosis. But if we can modify epidemiological diagnosis, we can say a person coming with fever and headache and rash and blah blah blah, and with exposure to mosquito bites, theoretically it can be possibly dengue, but not confirmatory. So for our purpose we can use that. Otherwise, a lab diagnosis with a clear-cut diagnostic criteria. Eligibility criteria also. Again, what the criteria? Yesterday I was talking to some of my colleagues in the gynecology department. So they wanted to do a study on PCOS. What is PCOS? PCOS to Polycystic ovarian syndrome. So now its name has changed. It's become polycystic metabolic ovarian, PMOS. They wanted to do a study on that. So they are again wondering how to do a study. Should we do it in our college? Should we do it outside? Should we do it in the medical college, nursing college, paramedical college, etc., etc.? So who are the eligibility criteria? Are you going to do it only among the nursing students? Are you going to do it among nursing staff? Are you going to do it among medical students, etc. Then source of cases, hospitals, can be either hospitals or it can be from the general population also. Controls must be free from disease under control, must be similar to the cases except for the disease under control. And sources of control can be either hospitals or general population or relatives or from the neighborhood. Okay, so selection of control, as I said, is very important. You cannot take a 25-year-old man and as a control for a 75-year-old person with cancer. Source of control, hospitals, general population, relatives, neighborhood. Then question matching. Okay. As I said, we take cases which are similar, age-wise, sex-wise, and match it. Otherwise, you might get wrong results. Then you have also confounding factor. Confounding factor is certain factors which affect both the risk factor as well as the disease. Like for example, alcohol and smoking. Both are risk factors for esophageal cancer, but they are also independent risk factors. Okay. So you cannot, these are confounding factors. Alcohol and smoking. Okay. Now, how do you measure the exposure? Somebody said, your friend on the first row, he said, you can ask by a questionnaire. You can have an interview, you can have a questionnaire. Interviews takes time. Questionnaire, you can give the questionnaire, but the problem is that they may return the questionnaire without properly looking at the questions or answering them. The data may be wrong. Past records, hospital and employment records. These are the measurements of exposure. Find out exposure rates among case and control to exposed factor and estimation of disease risk associated with the exposure. Okay. Now coming back to another question, smoking and lung cancer. Now totally how many cases is there? Totally how many cases is there? Kakaji, sure. How many cases there in this? Total how many cases there? Totally how many cases there? Total quota cases. Total. Population.
Cases 35.
35. Total quota.
वो केस बोल रहे हैं तो
The
टोटल
total number of people.
टोटल नंबर 117.
117. Okay. Total number of, I have used the word case. Total number of people is 117. Now, how many people are there with CA lung? How many people are there with CA lung? Cancer lung. How many people are there? Cases with CA lung. Total.
35.
Huh? Bolo, bolo.
35.
35. Okay. How many people are in the controls without CA lung?
82.
Huh? Bolo, Joseph?
82.
82. Okay, fine. Now, among the people with CA lung, how many are smokers? 33. Okay, fine. So 88 smokers in all, 33 of whom have CA lung, right? And non-smokers are there. How many non-smokers are total?
Total
Total number of non-smokers?
29.
29. Okay. So you have some idea of this. Now, we are going a bit further up. It's a case control study, mind you. So 35 cases of CA lung among total of, so exposure rates of CA lung among smokers is how much? Exposure of CA lung among smokers, how much is it? How many smokers have CA lung? Or rather, among the CA lung people, how many are smokers? Very good, 33 out of 35. So 33 out of 35, which is 94.2%. Among the controls, now remember the controls also, there are people who have got cancers. Okay. Now, so how many people have got cancer among the controls? Among the controls, how many have got cancer?
55. 55.
55. How many? He's saying that 33 out of 35 of cases have got are smokers. Of people with lung cancer, 33 are smokers. Similarly, how many of How many of them are among the controllers? How many of them are total? How many smokers? A by, okay. A by, what was this formula? A by A plus C. Right. A by A plus C is, what is this thing? A by A plus C is 33 by 35. That is the number of people. Among the CA lung people, how many are smokers? Now, how many are there without CA lung who are smokers? How many are there? A by A plus C is the number of people who are affected by CA lung, out of which how many are smokers? Or as the percentage of people, it's not percentage, the proportion of people who are smokers and who have CA lung is A by A plus C. Now I want to tell you, I want to know what is the proportion of smokers among those who do not have CA lung. Proportion of smokers among those who do not have CA lung.
27.
27.
The 29. No.
People who do not have, who are smoked but do not have CA lung. How many are there? Who are smokers but do not have CA lung. Who are smokers but do not have CA lung. Kato ache?
So B by B plus D.
B is the people who are smokers but who do not have CA lung. And total is B by B plus D. Okay. Is it clear? Not clear. Clear or not clear? 55 is the number of smokers who do not have CA lung, and 27 is the non-smokers who do not have CA lung. So, exposure rates among smokers is A by A plus C, 33 by 35, which is 94.2%. Exposure among controls is 55 by 82, B by B plus D, 67%. So, frequency of smoking was higher among lung patients than those without cancer. Okay, so that is, so now we come back to the odds ratio. The proportion, the ratio of the events in which an event can occur to the number of ways an event cannot occur. Or ratio of the odds that the cases were exposed to the odds that the controls were exposed to. So, again, odds that the case was exposed to are A by C. A by C, and odds that the control was exposed to was B by D. So, when you do a cross product thing, it becomes AD by BC. So, odds ratio is AD by BC. Just remember this. AD by BC. So, odds that estimation of risk is odds that the controls were exposed, A by C. Odds that controls were exposed, B by D. Odds ratio is AC by B or AD by BC or 8.1. So 8.1 means they have the chance is that there's a very high correlation, and smoking was found to be associated 8.1 times more in patients with lung cancer than those without lung cancer. Okay, is this part clear? AD by BC is the odds ratio. What is AD by BC? You go back to this thing, AD, 82 into 33 divided by 35 into 55, that comes to 8.1 in this particular case, which means smoking is found to be associated 8.1 times more in patients with lung cancer than those without lung cancer. Okay. Now, this is an interpretation of study in North Carolina, USA. Odds ratio was 4. This tells us that individuals who consumed a high fat diet have 4 times the odds of colon cancer than people who do not consume a high fat diet. So this was a case control study to determine if there is an association between colon cancer and high fat diet. So cases were all confirmed colon cancers in 2010. Controls were sample of residents without colon cancer. Odds ratio is 4. So this tells us that there's a 4 times more risk of people who consume high fat diet have a 4 times more risk of getting cancer. Now coming to the advantages of a case control study, obviously good for studying rare diseases, less time required. You can look at multiple risk factors, not just one. So for your thesis or your research project, you're looking at multiple risk factors. For example, if I say that the soil of a disease of an area is responsible also for cancer, then you look into that, the climate, whatever else. Okay, multiple risk factors, or can answer questions that could not be answered through other study designs. Disadvantage is that they rely on memory. They rely on memory, and people will try to recall that if there is something affected in your house or in your family. Okay, what do I mean by that? Say on the 2 years back on this day, where were you? 2 years back on this day, where were you? 3 or 4 years back. Medical here itself. Okay. What were you doing? You don't remember. Okay. Somebody else 4 years back. Why were you in college? What were you doing? You were in first year. Okay. So you remember that you were in first year. But you go a little further. You may be remembering because you're all educated and all. But if you ask somebody, did you have corona? He may not remember. He may say, I don't have corona. Did your parents get corona? I have to ask my parents. So that memory recall is very important. That's also called recall bias. And it's difficult to find a suitable control group. Incidents cannot be measured and not suitable for evaluation of treatment. But generally, case control is a very good study, a very good tool method. Now coming to the cohort study. Here we are looking at, cohort is a group of people, by the way. It is done to support the existence of association between suspected cause and disease. Now here, in cross-sectional studies or case control studies, we cannot really determine whether exposure risk factor preceded the disease or outcome. Okay. So somebody says, I've started suffering from cough and fever after COVID. We cannot surely say that. So here is the presence or absence of risk factor is determined before outcome occurs. So what do I say by presence of determined before outcome occurs? Now I am saying that, I am making an assumption that 50% of doctors will wear specs by the time they do their PG. 50% of doctors will be wearing spectacles by the time they start their postgraduate studies. So how do I know that? I am trying to follow you people up till you get your PG. Okay. So the presence of risk factor is determined for the outcome occurs. So cohort is a group of people who share the same experience within a different period of time. It can be birth cohort, marriage cohort, exposure cohort, synthetic cohort, etc. A group of people, your students, for example, those who were born in a particular year, those who did from the same village, same district, etc., etc. So that is a group of people who share the common characteristic or experience within a definite period of time. Again, you can have longitudinal studies. It's also called a prospective study, forward-looking study. Incident study starts with people free of the disease. Assesses exposure at baseline, assess disease status at follow-up. Okay. Now, if you are doing a study on, say, a particular group, you're following them for 5 years, and you're seeing that after 5 years, how many of them develop cancer? Let's put it this way. Here, so you're starting with people free of disease. You study the exposure. They're all exposed to radiation now. None of them have cancer. But over 10 years, how many have cancer? So you're actually looking at the real figures of cancer, not a vague figure. And assess disease status at follow-up. So you're starting with people free of disease, a group of people living in an area where there's a new power plant is coming up. You are assessing the exposure at startup, following them for 5 or 10 years to find out how many of them have cancer. Indications of a cohort study when there is good evidence of exposure and disease. So there is a risk of exposure to cancer if there are some other things like radiation and all. So that case there is a good evidence. So you go for a cohort study. When exposure is rare, but incidence of disease is higher among exposed. So if the number of cases of cancer are high among the radiation people who get radiation, that is a situation when exposure is rare, but incidence of disease is higher. When follow-up is easy, here's the biggest part. When follow-up is easy, cohort is stable. So here you need to follow the person up for 5, 10 years, whatever it is. Then it is stable. Otherwise, there will be loss to follow-up, there will be deaths, missing, etc. And again, when ample funds are available, you need funds for doing it. It's not easy. Case control is easy. Just pick up a case, get control and do it. This you need follow-up, you need funds. So here is the case control. What has happened? The outcome has occurred in the case control, that is yes. And you are going forward, you are going backwards. The exposure is there and the outcome has already occurred. So cohort study population free of the disease, but the risk factor is present, risk factor is absent. Some of them have got disease, some of them don't have the disease. And it is, so the study begins there, you are moving forward in time. Okay. So population, the core population is population without disease. Some of them are exposed to the disease, some are not exposed to the risk factor, sorry. Some of them get the disease, some don't get the disease. So basically this is a cohort, thing of a cohort study. You're looking at a population, none of them have the disease, but you're following them up because there's a risk factor. Some of them are exposed to risk factor, some of them not exposed. Some of them are exposed to risk factor, get the disease. Some of them not exposed to risk factor but do not get a disease. And again, no disease for the other population. So once again, the same thing. Here, how many have the disease? So exposure status is, in a study cohort is exposure status. How many have been exposed here is A plus B. A plus B people have been exposed. Not exposed are C plus D. C plus D is the comparison cohort. People with the disease is A plus C. Please look here carefully. And here without disease is B plus D. Just look at this. Maybe you can take a screenshot of this if you want. Study cohort is A plus B. Comparison cohort is C plus D. People with the disease is A plus C. People without the disease is B plus D. Is this clear? A plus B have a disease.
A plus C.
A plus C, yeah, A plus C. How many have got exposure? How many have this? What is the study cohort? So what is study cohort?
A plus B.
A plus B is a study cohort. A plus C has a disease. People who don't have the disease are B plus D. Okay. So here once again, what is retrospective cohort study? You have a prospective cohort study. You're going forward in time. You're following it up. Retrospective is you're going backwards. So what is an example of retrospective cohort study? Say for example, people who suffered from COVID, they are now coming with chest infections. So you are looking at the retrospective cohort study, you're going back in time. Okay. Or children born to pregnant women during COVID. You're going back and looking back in time. Okay. So that is a retrospective cohort study. And you can have a combination of prospective and retrospective cohort study. So both these are important. So it need not mean that a prospective study, cohort study should be always prospective. It can also be retrospective. Can you give an example of retrospective cohort study? Retrospective study, as I said, number of people who had COVID, they're coming with chest infection now, you're going back in time. Or the number of children of COVID mothers, what is the status now? So that is the example of retrospective cohort study. Prospective cohort study is exposure is there, disease occurs over time, and the study starts Okay. Retrospective is, the thing has already occurred. The example I gave you, COVID is there. The mother had COVID, the child is born. What is the status now? Or the person had COVID, he is suffering from chest disease now. That is the retrospective cohort study. So cohort studies, this is it, retrospective and and also it can be in both directions, both ambidirection. Exposure is still carrying on. Exposure is there, exposure is still going on and can go both ways. So here, these are some criteria for selection of cohorts. Both the cohorts should be free of the disease. Both the study group and the control group. Both should be equally susceptible to disease. Say for example, people living in an area where there's a power plant is coming up or a nuclear power plant is coming, they can be exposed to radiation. So both groups should be equally susceptible to disease. Both groups should be comparable. Diagnostic and eligibility criteria for the disease should be defined well in advance. Element of cohort study is important. Selection of study subjects, obtaining data on exposure, selection of comparison group, follow-up, analysis. Selection of study samples, general population, whole population area, representative sample, again special group, occupational group, it can be a professional group, exposure group, people for example having exposure to physical, chemical or biological agent. For example, X-ray exposure in radiologists. Many radiologists suffer from later life of cancer because of exposure to X-rays. Okay. Exposing, getting data, personal interviews, email, mail questionnaire, review of records, dose of drug, radiation, type of surgery, medical examination of special tests like blood pressure, cholesterol, etc. Obtaining data on exposure like water, air, sanitation. By obtaining the data of exposure, we can classify cohorts as exposed, non-exposed, and by degree of exposure, we can also subclassify cohort. Okay, by degree of exposure means somebody is going to work 3 days a week, he gets exposed so much, but somebody goes to 5 days a week, he gets more exposed to radiation. Then again, there can be internal comparison and external comparison. Internal comparison is only one cohort, one group, and subclassified and internal comparison is done. External comparison is with another group. For example, radiologist with ophthalmologist. Radiologist is exposed to radiation, ophthalmologist is not exposed to radiation. So you are comparing, say for example, cancer among doctors. Cancer among doctors, you are taking one group which is radiologist, one group of which is ophthalmologist. Radiologist is exposed to radiation, ophthalmologist is not exposed. If comparison is not there in the general population, we can compare with, if you don't have normal population, you can compare with general population. Like cancer rate of uranium minors with cancer in the general population. You're looking at cancer among the minors with cancer among the general population. Follow-up. Follow-up is either mail questionnaire, telephone call, personal interview, periodic medical examination, reviewing records, surveillance of death records. Follow-up is the biggest problem here and the most critical part of the study. What is the problem with follow-up? What is the problem with follow-up? Follow-up में असुविधा क्या है? What is the problem with follow-up? Long-term what?
Long-term monitoring.
Long-term monitoring. What is the issue? Long-term monitoring. What is the issue?
The person not
Person not? Where's your house?
cooperating.
Not cooperating. Not just cooperation. Where's your house? Where's your house? Kolkata. Okay. Where? Dakshin. Okay. So what? Not cooperating. No. What is the other thing? What is the problem with follow-up? Where's your house? Huh? Kolkata Tollgate. What is the problem with follow-up?
I lose contact or
Yeah, why? How will you lose contact?
they will lose the interest.
Not interest alone. After 5 years, will you be in tolerance? After 5 years, will you be in tolerance? You're not sure. After 5 years, will you be in Dakshineshwar? You're not sure. So
Not
letters
sure.
sent to you. You're probably studying some other place, going somewhere else. Somebody's got married, somebody's started practice. So biggest problem is follow-up. Follow-up, you will get people who have changed their address, their migration, change of occupation. Loss to follow-up is the main problem with cohort study. This is the biggest problem. People have moved. After 5 years, you've shifted to some other state, some other country. The loss to follow is one of the biggest drawbacks. Analysis, calculation of incidence rate among exposed and non-exposed, estimation of risk. Same thing we have talked about many times. And we won't go to A by A plus B. Among incidence among non-exposed, C by C plus D. Attributable risk, we will not talk about this. Again, now this is a question which I am going to ask you. Calculate the relative risk. What is the relative risk for the above data? Relative risk is 70 divided by 7,000. Incidence of cancers among smokers. What is the incidence of cancer among smokers? What is the incidence of cancer among smokers? Just tell me the formula. Incidence of, how many smokers are there? Professor Mola? How many smokers are there? Huh? How many smokers are there? How many smokers are there? Total, how many smokers are there? 7,000 smokers. How many of them have lung cancer? Huh? 70. So, percentage of lung cancer among how many of the smokers? Among the smokers, how many have lung cancer? 70 by 7,000. Incidence of lung cancer? Huh?
Actually, my grandmother is very sick, so can I go and to go home?
Okay.
Thank you, sir.
70 by 1,000. Incidence of lung cancer among non-smokers is 3 by 3,000. That is 1 per 1,000. Okay. So 10 per 1,000 and here is 1 per 1,000. So these are the incidence rates. So relative risk is 10 divided by 1, which means 10 times more common among smokers than non-common smokers. Attributable risk is 10 minus 1 by 10, that is 90%, which means 90% of cases among lung cancer among smokers are attributed to the habit of smoking. Strength of cohort study can establish population-based incidence. Accurate relative risk can examine rare exposure, can establish cause and effect, minimizes selection and information bias. It can be used where randomization is not possible, more than one disease related to single exposure, and multiple outcomes can be studied like smoking, lung cancer, COPD, etc. Weakness, it requires a large sample. Ethical issues are there. What are the ethical issues? You are following somebody who's got cancer and you are exposing him to radiation. So that poor chap, because of your study, he's exposed to radiation further. You can tell him, why don't you shift your house? Or somebody is smoking, continuously smoking. For your study, he's a good subject, but he's having a health problem. So that is the ethical issue. Non-response, migration, loss to follow-up. Unexpected environmental changes may affect the influenza association. So this is another thing which is very, from the net I've picked up. We'll not talk about this. There's not much time. I think I've talked to you. We'll show this in the next slide, in the next thing. So odds ratio is the important thing. Measure of strength and association with risk factor and outcome. This is 3 assumptions. Cases must be relatively rare, must be representative of those with the disease. Controls must be representative of those without a disease. So again, odds ratio, this is, when the odds ratio is high, it means there is a clear-cut association. Relative risk is measure of association between incidence of disease and factor being investigated. The interpretation of relative risk, 1 means no association. If it is more than 1, it means there is a positive association. That means there is a chance that cancer could be due to this or some disease could be due to this factor. Negative association means a protective effect. For example, vaccination. Vaccination against HPV, for example, after 5 years you find the incidence of cervical cancer has decreased. Maybe the relative risk will be less than 1. So that means it has a protective effect. So this is the formula for relative risk which I just showed you. Incidence rate among exposed divided by incidence rate among unexposed is A by A plus B divided by C plus D. So this we've talked about. So that's all for now. Okay.